Welcome back. Let's jump back into our discussion. Moving on to eating disorders. This is a different kind of challenge. While substance abuse often comes with external chaos, loud scenes, police, physical risks, eating disorder calls are usually quieter but can be just as dangerous for the patient. What is an eating disorder? It's basically a serious disturbance in how a person eats, coupled with an obsession with weight or body image that leads to unhealthy and often dangerous behaviors. These are classified as mental health disorders because they involve distorted thoughts and emotions around food and weight, but they manifest with very real physical health consequences. The two major eating disorders we'll focus on are anorexia nervosa and bulimia nervosa. Anorexia nervosa. This is characterized by self starvation. The person, often a teenage girl, but not always, restricts their food intake so severely that they drop to a dangerously low body weight. They have an intense fear of gaining weight and a distorted perception of their own body. They might see themselves as fat even when they're emaciated. They often exercise excessively, and they might also engage in purging behaviors sometimes, but primarily it's caloric restriction. Bulimia nervosa. This involves cycles of binge eating, consuming a large amount of food in a short period, followed by purging to compensate for the binge, typically by vomiting or using laxatives, sometimes excessive exercise or fasting after a binge as well. Unlike anorexia, people with bulimia can be normal weight or even overweight. Their dangerous behavior is the frequent purging, which causes internal havoc despite their weight maybe appearing normal. There's also binge eating disorder, where a person binges like in bulimia but does not regularly purge afterward. These individuals often become overweight or obese and feel a lot of shame about their binge eating. While binge eating disorder can lead to long term health issues like diabetes, heart disease, it's the anorexia and bulimia that we usually see in acute medical crisis via EMS. Anorexia due to malnutrition and bulimia due to things like electrolyte crises or GI damage. Who gets eating disorders? Statistically, the majority are females in their teens and 20s. But don't let that stereotype fool you. Males can and do develop eating disorders, sometimes focus more on muscularity or weight categories in sports, etc. And older women or younger kids can as well. It can affect any demographic, though, yes, if you get a call for a collapse of a 17-year-old girl who's very thin, an eating disorder should be on your radar given the prevalence in that group. Eating disorders are not rare. Up to 5% of the population experiences one at some point. Think of a high school of 1,000 students. Statistically, dozens of them might be silently struggling with disordered eating to some degree. The seriousness cannot be overstated. These are not fad diets or vanity gone wrong. They are complex, life threatening illnesses. Anorexia nervosa, in particular, has an alarmingly high mortality rate. Patients with severe anorexia can die from malnutrition, cardiac arrest, suicide, or other complications. Bulimia can also be fatal, for instance, if someone has a heart dysrhythmia from low potassium or tears their esophagus, causing internal bleeding. We as EMS might be literally the first medical professionals to see these patients, because many hide their illness until a major medical collapse occurs. So when we get called to a possible eating disorder case, often it's an acute medical issue. Person fainted, a seizure, heart palpitations, etc. We might only realize it's an eating disorder when we see the context or history. It's important to keep that differential in mind, especially with young women in particular, but also in others. If you find someone who's extremely underweight or you get clues like a history of an eating disorder, you have to factor that in your assessment. Let's explore why eating disorders develop psychologically and what they do to the body physiologically. This will shed light on why these patients present the way they do and what complications we need to watch for. Starting with the psychological factors, a central feature in both anorexia and bulimia is a disturbed body image and fear of gaining weight. In anorexia, even a skeletal patient may look in the mirror and perceive themselves as overweight. This is a true distortion of perception. There's also often an element of needing control. Patients with anorexia frequently are high achievers, perfectionists, or feel that controlling their food is the one area they have absolute say over. Life stresses, trauma, family dynamics, they can't control those, but they can control what they eat, and it becomes an obsession. Similarly, bulimic patients often feel guilt and self hate around their eating. The binge happens often in response to stress or negative emotion, and then the purge is a desperate attempt to undo it and regain control. It's a vicious emotional cycle. There are also cultural and social factors. Modern society often equates thinness with beauty and success, which can fuel especially young people to take dieting to dangerous extremes. However, an eating disorder is not simply an extreme diet. It's usually accompanied by underlying issues like low self esteem, anxiety disorders, or obsessive compulsive traits. In fact, OCD, obsessive compulsive disorder, and eating disorders have some similarities: the obsessive thoughts about food and body, and compulsive behaviors like ritualistic eating or exercise routines. Many anorexic patients have an almost phobic response to eating certain foods. There's also evidence of genetic predisposition. If someone has a family member with an eating disorder, their risk is higher, and certain personality types, again, perfectionistic, anxious, are more prone. Often, eating disorders can be triggered by a significant life event or change, like puberty, leaving for college, a comment from a coach or parent about weight, etc. In summary, psychologically, these disorders are about an intense fear of weight gain and distorted self image, combined with using eating behaviors to cope with or exert control over emotional pain or stress. They are very compulsive and difficult for the person to simply stop. Telling an anorexic, just eat, is as ineffective as telling an addict, just stop using. Now, the physiology, starvation, and repeated purging wreak havoc on the body. I'll break it down by system. Cardiovascular. The heart muscle suffers in anorexia. The body, lacking nutrition, starts breaking down muscle, including the heart, for energy. Electrolytes like potassium and magnesium often become depleted, especially if vomiting or using diuretics. This leads to dysrhythmias. Anorexic patients commonly have bradycardia, heart rates in the 30s or 40s, because their metabolism is so slow. Low blood pressure is common, and they might experience orthostatic hypotension, dizziness upon standing, and fainting. In severe cases, cardiac arrest can happen, either from a dysrhythmia or from the heart just being too weak. Bulimic patients, due to electrolyte swings, especially low potassium from vomiting, are at risk of dysrhythmias like ventricular tachycardia or fibrillation. One signature of dangerously low potassium is a cardiac arrest in a young person with no other cause. Suspect an eating disorder if you ever encounter that. Neurological. The brain runs on glucose, and prolonged malnutrition means the brain isn't getting enough fuel. Patients can become confused, lethargic, or even comatose in extreme cases. Seizures can occur often due to electrolyte imbalances. Severe hyponatremia from someone who, say, drinks tons of water to feel full, as in that case study we saw, or from drastic shifts like refeeding syndrome. Also, poor circulation and anemia, common in anorexia, mean less oxygen to the brain, which contributes to dizziness and fainting. Endocrine, metabolic. The body goes into survival mode in anorexia. Hormone levels shift. Thyroid hormones drop, so they become cold intolerant, sluggish metabolism. Stress hormones like cortisol may rise, and in females, estrogen drops, causing cessation of menstrual cycles, amenorrhea. They often have bone density loss, osteoporosis, because of hormonal changes and lack of nutrients like calcium, vitamin D. Bulimic patients might not have as severe calorie deprivation, so these changes can be less pronounced, but if they also restrict between binges, they could. Temperature regulation. Anorexic individuals often have a low core body temp. They'll feel cold all the time and sometimes develop lanugo, which is fine downy hair on their skin. The body's weird attempt to insulate itself in the absence of fat. It's like what newborn babies have since they can't regulate heat well. GI system. In anorexia, everything slows down. They often have constipation. Little intake equals little output. In bulimia, the repetitive vomiting causes issues: esophagitis, acid reflux, potentially tears in the esophagus. Mallory-Weiss tears can cause vomiting of blood. A full rupture, Boerhaave's syndrome, is a surgical emergency. They can get gastritis, and the laxative abuse can cause serious colon problems and dehydration. Some patients with bulimia also develop something called pancreatitis from the erratic eating patterns. Renal. Dehydration is a big issue, especially in both anorexia and bulimia. They might have low blood flow to kidneys, causing prerenal azotemia, like a prerenal failure picture. Electrolyte disturbances affect kidney function as well, and diuretic abuse, some take water pills to lose weight, directly messes up kidney function and electrolytes. Hematologic are immune. Severe malnutrition leads to anemia, low red blood cells, and leukopenia, low white cells. So these patients can be prone to infections and feel very weak. Poor wound healing is noted. If they get a cut or sore, it heals slowly due to lack of protein. So, physically, an eating disorder can impact every organ system. That's why when one of these patients decompensates, they can be in a truly precarious state. For EMS, when you find a patient who is, say, extremely underweight, you should immediately think, okay, what are my concerns? Likely cardiac, dysrhythmia, or arrest, electrolytes, maybe seizures or dysrhythmias, fluid status, shock from dehydration, and glucose, hypoglycemia. Also, how fragile they are. Moving a severely osteoporotic anorexic could potentially cause a fracture, for example. To mention purging complications specifically, in bulimia, aside from what I mentioned, frequent vomiting can cause the teeth to erode, acid eats the enamel. Dentists often catch bulimia from tooth decay patterns. They may have swollen parotid glands, the saliva glands near the cheeks, from constant vomiting, giving a bit of a chipmunk cheek look. And they might have those knuckle calluses or scars, called Russell's sign, from using their hands to induce gagging. These are subtle signs, but as EMS, you might notice them if you're observant, and they can confirm what you suspect. All right, that's a lot of pathophysiology. The key point: eating disorders are not benign. They deeply affect the body, and as the one responding to an acute collapse or crisis, you need to be prepared for things like low vital signs, dysrhythmias, seizures, or even cardiac arrest. We treat what we find, but understanding where it's coming from, starvation, electrolyte loss, helps in anticipating what might happen next. Now, let's look at comorbidities and warning signs specifically, then what we do as EMS. Just as with substance abuse, eating disorders often come packaged with other mental health issues. Depression is very common. Imagine starving yourself. It's isolating and physically depressing, plus, many had underlying depression to start. Anxiety disorders, especially social anxiety and OCD, frequently coexist. There's a noted link between OCD and anorexia in terms of perfectionism and ritualistic behavior. Also, a significant number of those with eating disorders have a history of trauma or abuse, which can lead to PTSD symptoms. And interestingly, as mentioned earlier, substance abuse can co occur. Up to 50% of people with an eating disorder also misuse alcohol or drugs. Bulimia has a particularly strong overlap with things like alcohol and stimulant abuse. So these patients might be dealing with a lot more than just their eating behavior. They might be depressed and suicidal. We should always assess for suicidal ideation. Some anorexic patients lose hope and attempt suicide, or they passively are okay with dying from their illness. They might be anxious or having panic attacks. Be aware of that because it might influence how you manage them. For example, a very anxious anorexic patient might freak out if we try to start an IV or push treatment too fast without explaining, etc. Now, warning signs of eating disorders: some we've covered: dramatic weight loss, preoccupation with food, refusal to eat around others, extreme dieting, secret eating, or hoarding food in binge eaters. From an EMS perspective, you might not witness their daily habits, but you might gather clues at the scene. For instance, if you're in the patient's home, you might notice the kitchen or fridge untouched or diet pills on the counter. Family might tell you she's been eating almost nothing and exercising all the time. Or we find laxative packages in the trash. Those are huge red flags. Physical signs are often more obvious. The patient's appearance: cachexia, extremely thin, sunken eyes, protruding ribs. Or if it's bulimia, maybe normal weight, but with those other signs, like dental issues or swollen cheeks. Vital signs: chronically low heart rate, low blood pressure, low temperature. They might be wearing layered or baggy clothing even in warm weather, classic for anorexia, both because they feel cold and to hide weight loss. If you shake their hand or touch their skin, it might be cold and perhaps you feel that fine hair, lanugo, on arms or back. We mentioned calloused knuckles from induced vomiting. If you see scarring on the top of the hand joints, that's a strong indicator of repeated self-induced vomiting. Dental. You likely won't be inspecting their teeth on scene, but if you happen to notice eroded yellowish teeth or lots of cavities in a young person, bulimia could be a cause. Dentists often pick this up, as I said. Breath. Sometimes you can smell vomit on their breath or a fruity acetonish odor from ketosis if they're not eating carbs. Fatigue and weakness. The patient might be extremely weak, can't stand without assistance due to muscle wasting and low blood pressure. Fainting spells. If a young patient has been fainting, that's a common presentation that leads to discovery of an eating disorder. They stand up, blood pressure tanks, out they go. Behaviorally, listen for statements or attitudes. The patient might say things like, "I don't deserve to eat," or "I'm so fat," when they're clearly underweight. Or they might resist treatment saying, "I'm fine, I just stood up too fast." Denial is very strong in anorexia. Often they don't recognize how dangerous their condition is. Or they do, but are so terrified of eating that they're willing to risk it. Family and friends can provide key intel. Maybe a parent says, "She's lost 30 pounds in 2 months and avoids eating with us." Or a friend says, "He's been vomiting after meals on purpose." That kind of info is gold for you to tailor your management and also pass to the hospital. In summary, the warning signs can be subtle or obvious. With eating disorders, often others around have noticed and it's been an ongoing concern. By the time EMS is called, usually something acute has happened: a collapse, severe weakness, abnormal vital signs, etc. So you're seeing the end result physically. But being aware of these signs helps confirm the underlying cause so you can treat the patient appropriately. For instance, knowing it's anorexia tells you, okay, likely bradycardic hypotensive, likely hypoglycemic, watch for dysrhythmia, etc. Also, identification is important for the hospital handoff. If you suspect an eating disorder and it isn't obvious to the receiving staff, make sure to mention it. It might seem obvious if the patient is rail thin, but I've seen cases where busy EDs focus on one thing and miss the big picture. You pointing it out can ensure they consult psych or appropriate specialists. So, bottom line, these patients often have other psychological issues, depression, anxiety, etc., and they show a variety of warning signs from physical, weight loss, vital sign changes, signs of purging, to behavioral, food rituals, secrecy, body image obsession. Now, how do we manage them? That's next. When responding to a call involving a suspected eating disorder patient, our approach has some differences from the substance abuse scenarios, but also some similarities in terms of being calm and supportive. Scene safety is typically less of a concern in terms of violence or hazards. It's rare for an eating disorder patient to be combative or pose a threat. More likely, the scene safety issues are medical. For example, if the patient fainted, they might have fallen in a bathroom or cramped area, so watch your footing and lifting mechanics. If they're in a bathtub or something, some patients with bulimia vomit in the bathroom and could pass out there. That's a confined space to extract from safely. Also, consider the emotional environment. Family may be very distraught, even arguing. Sometimes parents and the patient might be in conflict. You have to eat. No, kind of fights. So there can be emotional intensity, but physical danger to responders is typically low. Still, if the patient is depressed and perhaps suicidal, keep an eye out for any self harm tools or medications around, less about your safety, more about their safety. Like, did they take a bunch of pills too? Law enforcement rarely is needed unless it's a case where the patient is a minor being forced to go to hospital and is resisting, or if suicidality requires a protective custody scenario. Approach the patient in a gentle, non threatening way. These patients are often embarrassed or in denial, and they may be very scared. An anorexic who's collapsed might actually be more terrified of the solution, gaining weight or being forced to eat, than of dying. It's hard to imagine, but that's the power of the illness. So be sensitive. Avoid any judgmental body language or facial expressions if you see how thin they are or find out about their behaviors. You want to build trust, not shame them. Also, avoid making comments like, "You're so skinny," or "You look terrible," obvious, but worth saying. Even compliments like, "You're actually looking better," can be misinterpreted. Better you're called fatter in their mind. It's tricky territory, so it's best to focus on health. Let's see what we can do to make you feel better. Communication. Use a calm, caring tone. If the patient is conscious and alert, engage them in conversation. Ask how they're feeling. Often they'll minimize their symptoms. "I'm just a little tired, that's all." You might have to gently point out, "Your heart rate is very low and you did lose consciousness. That's not normal tiredness. That's your body telling us it needs help." They may be resistant to going to the hospital out of fear. Emphasize that your job right now is to ensure she's medically stable. "I'm not here to force you to do anything, but I am worried about how your heart is doing. I'd feel a lot better if we got you checked out." Be prepared that some anorexic patients, even in a crisis, will say, "I don't want treatment." If they're an adult and appear lucid, we have the same capacity issue to consider as we did with the overdoses. An anorexic who is severely malnourished might lack capacity in that their brain is not nutritionally functioning well, or they might be in a disordered mental state. More on that in management. At the approach stage, just note any such statements and start formulating a plan. Involve family, medical control, etc. if refusal comes up. If family is present, they can be either a great ally or an additional stressor. Some families are very supportive and can coax the patient along. "Honey, we love you, we're scared, please let them help." Others might be angry or frustrated. "Why are you doing this to yourself?" If it's the latter, it might help to separate a bit and talk to the patient alone in the ambulance to reduce stress. Gathering history carefully, ask simple, non judgy questions. "Have you been diagnosed with an eating disorder?" Sometimes they'll say yes, sometimes they'll deflect. If the patient is a minor, parents will usually fill you in. "Yes, she has anorexia, she's seeing a therapist." Or sometimes, "We suspect it, but she hasn't been diagnosed." It's important to find out about intake. "When is the last time you ate or drank anything?" They might say, "I had a small salad yesterday," or something. Gives you an idea of how depleted they are or if hypoglycemia is likely. Ask about purging. "Do you ever make yourself vomit or use any pills to lose weight?" If they're shy to answer, I often soften it with, "I'm asking because it helps me understand what medical problems to look for, not to judge you." They might nod or say, "Yes, I vomit sometimes," or "I take laxatives." If yes, ask, "When is the last time you did that?" Because if they just vomited multiple times today, their electrolytes might be especially off. Also, check for co-ingestants. Ironically, some might also misuse substances, like diet pills, which often are basically stimulants, or even illicit drugs like cocaine or Adderall to suppress appetite. Or if depressed, maybe a medication overdose on top of starvation. It's worth gently asking, did you take anything else, like any medications or drugs, intentionally or unintentionally? If it's a collapse, maybe not. But if it's a found unresponsive scenario, you never know. Throughout the interaction, maintain that compassionate demeanor. Even if you personally are thinking, just eat something, never say that. Instead, focus on immediate needs. We need to take care of your body right now. I sometimes liken it to any other illness. Just like a diabetic can get very sick if their blood sugar is too low, you're very sick right now because your body is low on a lot of things it needs. We're going to help you get those back up safely. It kind of medicalizes it rather than moralizes it. Ensure privacy and dignity. These patients already feel very vulnerable. If they're scantily dressed, maybe just in underwear or a light shirt due to fainting at home, cover them up with a sheet or blanket when possible to preserve modesty and also keep them warm. If bystanders or others are gawking, politely ask them to give the patient some space. On the ambulance, try to have only necessary personnel present. So the approach, respectful, gentle, and reassuring. Unlike a combative OD, here you're more in a role of a supportive caregiver coaxing someone who might be frightened. Think of how you'd approach someone who is very fragile both physically and mentally. That's basically it. Now we'll move into the treatment priorities and any special considerations while transporting an eating disorder patient. Time to talk about what we do for these patients as EMTs. We've already touched on assessment bits, but let's organize it. As always, ABCs first. Usually, airway is fine unless they had an event like a seizure or are severely obtunded. Breathing might be okay, albeit maybe shallow if weak. Circulation is often the big one. You may find a very slow heart rate, bradycardia, and low blood pressure. If the patient is conscious, they might be okay with those vitals at rest, but if they stand or exert, they could collapse, orthostatic hypotension leading to syncope. If the patient is in really bad shape, unresponsive or barely responsive, treat it like any other patient. Support airway and breathing. Maybe they had a cardiac arrest from a dysrhythmia, then it's full ACLS mode with CPR/AED. But assuming they're still alive and with a pulse when we get there, likely since we're discussing it, checking vitals will give us clues. Vital sign management. If BP is low, we take steps like keeping them supine, head flat, to maximize cerebral perfusion. Raise legs if no contraindication. If pulse is very slow and they're symptomatic, like very dizzy or altered, that's concerning for impending cardiac issues. ALS might give atropine if needed, but often the fix is addressing underlying issues, fluids if dehydrated, etc. Temperature, if they're hypothermic, which many anorexics are mildly, warm them with blankets. Don't do aggressive rewarming like for a drowning victim, just passive warming. They usually aren't extremely hypothermic, just a few degrees low. Glucose. Check that blood sugar. These patients can have dangerously low blood glucose. In our scenario, it was 35. No wonder she was out of it. If it is low and they're awake enough, give oral glucose or something sugary they can swallow. If they're not alert enough, then ALS, IV dextrose, or even IM glucagon if available. But note, if they are severely malnourished, even a bit of glucose can sometimes trigger refeeding issues, but in an acute low sugar scenario, the immediate need is to get it up to a safe level. We can't worry about the nuance of refeeding syndrome in the field when the brain needs sugar now. So treat hypoglycemia promptly, just don't overshoot. You're not trying to get them to eat a full meal, just enough to normalize sugar. Hydration and shock. Many anorexic or bulimic patients are chronically dehydrated. If the patient shows signs of poor perfusion, tachycardia, which ironically might not happen if they're bradycardic by baseline, but maybe weak pulse, low BP, altered mental status, treat for shock. As an EMT, that means positioning, supine, legs elevated if tolerated, keeping them warm, and rapid transport. If you have the ability to start IVs, you'd give IV fluids, but at a moderate rate, not flooding them. There is a risk in refeeding hydrating too quickly. Refeeding syndrome, where a sudden influx of glucose and nutrients causes a surge of insulin and then electrolytes shift into cells leading to things like low phosphate, which can be fatal. However, in the acute EMS timeframe, giving a reasonable fluid bolus for someone hypotensive is necessary. Generally, 1 liter of normal saline isn't likely to trigger full refeeding syndrome. That happens when you aggressively feed them calories. But just be aware, If they've been starved, even IV fluids with dextrose, like D5, can contribute, so usually plain saline is used initially if needed. That detail might be more than you need, but I mention it to highlight why not to overdo things. A gentle approach is good. Monitoring. Put them on a heart monitor if you can. Even a basic ECG or the ambulance's monitor if you're trained, or at least be mindful of their pulse. If you see an irregular or very slow rhythm, that's critical to relay. If something like VTAC occurs, that's a cardiac arrest protocol scenario. Oxygen. Usually, an eating disorder patient isn't hypoxic unless there's another issue, like anemia could cause some oxygen delivery issues. It doesn't hurt to give a little O2 if you suspect any perfusion issues or if they're complaining of chest pain or shortness of breath. It's not mandatory for every case, but certainly for any that lost consciousness or have cardiac symptoms, go ahead and give oxygen. Avoiding harm. One important thing, as I alluded to, avoid forcing any oral intake beyond what's needed for an acute fix, like glucose for hypoglycemia. Don't try to give them water or food thinking they need to eat. While well intentioned, it can cause problems. If the patient is starving, they will need refeeding under medical supervision with careful electrolyte monitoring. If you hand them a sandwich and they gulp it, they could actually precipitate dangerous electrolyte shifts or overwhelm their shrunken stomach, possibly causing vomiting or refeeding syndrome issues. Also, psychologically, forcing food is the worst thing you can do from a trust standpoint. They will panic or resist. So we treat immediate threats, like sugar if super low, but we do not attempt to correct their malnutrition on scene beyond that. Seizures or other acute events. If they seize, maybe from low sodium or low sugar, handle like any seizure. Protect airway, prevent injury, check glucose, call ALS for meds if it's prolonged. If they have chest pain, treat as possible MI. Anorexics can have heart attacks due to electrolyte issues or just strain on the heart. We would give aspirin if not contraindicated and they can chew, though in a young anorexic, MI is less likely than dysrhythmia, but chest pain could also be an esophageal tear or something in bulimia. Hard to diagnose in field, so treat symptomatically and transport. Mental health hold. Now, ethically and legally, if this is a minor, you have fairly clear ground to transport under parental consent or implied consent if life threatening. If it's an adult who is refusing, you have to gauge capacity. A starving brain may not be competent to decline care. The law in many places allows involuntary transport if someone is a danger to themselves due to a mental illness. Anorexia qualifies, it is essentially slow suicide in extreme cases, though the patient's intention isn't to die, they just can't see that they are dying. As EMS, typically we would involve medical control or law enforcement if needed to facilitate an involuntary commitment for an adult who is refusing but clearly at risk. It's a delicate area. You might say to the patient, I respect your right to decide normally, but right now your body is in a critical state. I'm really worried that if we don't get you help today, you might not wake up tomorrow. I would rather you come willingly, but if you absolutely refuse, we may have to involve others because we can't, in good conscience, leave you like this. That often convinces them, or at least they acquiesce. They may be angry, but it's better than them dying. Documentation. We'll thoroughly document vital signs, what the patient says. PT admits to anorexia, states she hasn't eaten in 3 days. Any statements of refusal or denial, and our interventions. This is a case where your documentation might be read by psych evaluators or others down the line, so clarity helps. Finally, transport. Ideally, transport to a hospital that has capabilities for both medical and psychiatric care. If your area has a specific eating disorder center, they'll likely still need to go to an ER first for stabilization. If available, inform the ED early if you suspect severe anorexia. They might want to prepare, maybe even have ICU on standby if the patient is critical. During transport, continue to monitor closely. If their heart rate suddenly changes or they become less responsive, be ready to manage airway or do CPR. One more ethic note, maintain confidentiality. Families often want to ride along or know everything. With minors, parents have the right to info. With adults, ask the patient if it's okay to talk openly in front of family. Many times, these situations are already well known to the family, but still, follow patient privacy wishes if they have capacity to make that decision. So, to sum up management, support their vital functions, especially circulation and glucose. Avoid doing anything that could destabilize them further, like overfeeding or aggressive fluids unless needed for shock, monitor for lethal complications, and get them to the hospital, all while keeping them as calm and comfortable as possible.